And I'd just like to introduce Dr. Carla Keirns. She's an assistant professor of medical ethics at the University of Kansas Medical Center. Dr. Keirns is a physician, clinical ethicist, and professor at the University of Kansas Medical Center. She practices palliative care, medicine, and serves as a clinical ethics consultant, as well as serving as lead faculty for ethics at KU's medical school. She has published in clinical ethics, health policy, and the history of medicine. And I think today we're going to talk a little bit about how pandemics end. So Carla, I'd just like to hand this off to you.
Thank you. So I'm gonna share my slides. There we go. Oh, I can't share.
Oh, let me give you that power really quick. How about now?
Yep, I'm good. Okay. Sounds like we may be getting a cameo from my research assistant who's 7.
All right.
Hey, are you gonna come say hi or go somewhere else? He's passing. Okay. So what I really wanted to talk to you about today is some ways of thinking about what's coming next. And it may sound ironic, but despite the fact that I'm trained in medicine, medical ethics, health services research, and history of medicine, it's actually the history that helps me think about and understand better what I might anticipate about the next 2 to 5 years of COVID-19. So there are some great timelines out there now about what has happened in the last year as we've gone from a few cases in China to almost 500,000 Americans dead and millions worldwide. Though WHO declared COVID-19 a pandemic toward the end of February of last year, and has been coordinating a lot of international efforts. But when I think about COVID-19 and how this will end. My 7-year-old will be able to go back to school. We will all be able to see each other again. And at the same time, again, with so many lost, this is going to reverberate for a very long time in the public and in families and in communities. We won't get my father-in-law back. He died in April from this. And so recognizing that our family's experiences multiplied millions-fold around the world, it can't but affect how societies are organized, how people think about politics, how people think about health and medicine, and risks to their families. But I am counting on first grade and second grade starting again in the fall. I hope I'm right. So how do epidemics end? Actually, the answer to that is really simple and straightforward. They end when the disease runs out of hosts. The disease can run out of hosts because it infects everyone. It can run out of hosts because we contain it in a small group of people. It can run out of hosts because we develop drugs and other methods to cure it or to reduce infectivity. It can burn through a population and kill large numbers of people, as this is doing. And at the same time, it isn't killing as many people as it would if we did nothing. So public health has been helping change who gets sick, where they get sick, and how many people get sick. Public health interventions are critical to understanding how we're going to deal with and how we can fight epidemic diseases. The term quarantine is from the Italian and dates to the Black Death, and when the Black Death and other diseases were transmitted along trade routes in Europe. It stands for quarantina, or 40 days, because ships arriving in Italian ports would be asked to sit at anchor for 40 days. and whoever was alive at the end of 40 days could come ashore. That was the best test they had, was time. You can use mitigation efforts, and those mitigation efforts can be industrial scale for some diseases that are waterborne. In particular, the development of municipal water supplies has been critical. The municipal sewer systems has been critical. And at human scale, even with diseases like cholera or Black Death or other things, humanity has always addressed them both at a societal level with quarantines and other kinds of large-scale public health efforts, but also at the home scale. Nancy Toms, historian of medicine at Stony Brook in New York, has a book, an article called The Private Side of Public Health, and a book called The Gospel of Germs that really explored this transformation in the late 19th and early 20th centuries, in which it was the job of women to protect their families from infectious diseases by regimens of cleaning and paying attention to where the risk points were, what would put their families in harm's way, and how could they be protected. We always think of magic bullets, vaccines, antibiotics, other kinds of treatments, because they are miraculous, and they truly are. The ability of a vaccine to protect from infection with this devastating virus is amazing. It's a triumph of science. It's a triumph of human ingenuity. And at the same time, as public health folks have been saying for generations, vaccines don't save lives unless they can get into the people who need them. And then I'm going to lead us with some troubling thoughts about reservoirs and emerging infectious diseases as we think about, again, futures and how to protect everyone. So the strategy of letting the disease burn through the population has been most forcefully stated in the US in the Great Barrington Declaration. We should just let young people get on with their lives and get sick, but protect those who live in nursing homes and other people who are more vulnerable. As a physician, the more vulnerable thing has troubled me throughout our discussions in the last year, because I have cared for people in their 20s and 30s and 40s and 50s who are dying of this disease. And the only reason I haven't cared for children is I don't care for children. But there have been hundreds of pediatric deaths in the United States. It certainly is nothing compared to the thousands and thousands of grandparents and older folks who we have lost. But this idea that there is anyone who is invulnerable is frankly offensive to me as a physician, because people who believe that put themselves and others in harm's way. That's my editorial opinion. So there are also a series of questions that were not answered and that we are still really beginning to understand at the time that this declaration was made. Does natural infection actually produce effective immunity? If so, how long does it last? And what should we make of viral evolution? So in homage to my mentor, Charles Rosenberg, historian of medicine at Harvard, an epidemic is a drama, and you can think about it as a play in 4 acts. That is what he argued. Using the examples like cholera that he wrote his first book on, HIV, tuberculosis, you can see it in any number of diseases. The first thing that happens is, as the first cases start to pop up, as we start to recognize maybe there is something new going on here, the first thing we do is say, no, it can't be. This can't be it. And in this case, the questions of could this really be the pandemic we've all been waiting for have led to other discussions. Is there something worse ahead of us? Is this really the worst that it can be? But that phenomenon of dealing with a catastrophe, whether in our personal lives or in our social life, has this phenomenon of the first thing we do is start to recognize what might be happening, and then we think it can't be. And then we start to say, oh, well, we'll figure it out. And so that bargaining process that, that we all often think of in terms of individual tragedies also plays out in social tragedies like this one. And finally, we get to mobilization. And so that's what we have been doing for most of the last year, is figuring out how are our healthcare systems going to respond? How are our schools going to respond? How are our families and employers and everyone else going to respond? Act 2, Charles tells us, is about managing randomness, because one of the things that separates epidemic and infectious diseases from many of the other diseases that we face is this idea that anyone could get it, and that anyone could get it today and be dead in a matter of hours or days or weeks when they had been previously healthy. And that randomness of the impact of infectious diseases is deeply unsettling, deeply offensive to people's understandings about how their lives should work, how their society should work. And so the process of figuring out how to block off randomness and how to say, no, no, it isn't random. If you do the right things, you'll be okay, is our way of dealing with the everyday life experience of the fact that maybe we'll be okay, maybe we won't. And so this, the separation that people often make of, I'm doing the right thing and therefore I'll be okay, or I did the right thing and how did I get sick anyway? And that kind of moral intuition starts early, very, very early. A few months after my father-in-law died of COVID-19, my son asked me, Mommy, why did Grandpa die of COVID? Didn't he know about masks? And I had to explain to him that masks were not a perfect protection, and at the same time assure him that we were going to be okay. So it's not just psychological and it's not just political. We all have to figure out how to manage in this kind of situation. And our previous generations had more practice than we do, because they were more used to this kind of uncertainty and catastrophe and randomness of infectious diseases. We still see these problems, but we don't see them as often. We don't see them as persistently in our lives. And so we don't understand them in the same way. Negotiating public response. So I could spend the rest of the hour talking about how the decisions that one group says we should do this and another group says we should do that, and how much money are we going to spend and which activities are we going to disrupt. But I don't need to do that, because everybody who is listening has lived this process for the last year. So I just want you to reflect that that is actually inevitable in the setting of this kind of infectious disease episode, that it's not that somehow this disease got more politicized than others. We could editorialize about whether it got politicized in ways that were helpful or not, but actually this back and forth between individuals and commercial enterprises and government and public health and other groups is a part of the process of dealing with an epidemic. And then I love that Charles puts the fourth act as subsidence, because in some ways it does feel like a wave or a geological phenomenon, because it's not like it's going to go away one day. It happens over time. It happens in ways that are uneven. It disappears in some communities, but not others. And so thinking about it with that kind of geologic metaphor he gives it, I think helps us appreciate the most important thing about the end of an epidemic, which is that it's not going to end for everyone at the same time. It's not going to end for everyone in the same way. We are, as a society, going to get through this, but we are not all as individuals going to get through this. And not everyone will be untouched, whether it's deaths or economic losses or other things. So this is, as many, as all of us will recognize, kind of your classic rise of COVID-19 in the last year, separated geographically. So when I look at this graph, I always think of this graph. And the thing about this graph of 1918 flu is that there was a small peak in June and July. Those who know that history recognize that some of the first cases were recognized at Fort Riley in Kansas. That we thought that that things were bad in July on the troop ships where it first really spread, but we had no idea what was coming. And so all spring and summer, I was waiting to see what did our October, November echo peak look like. And I was sad, but not surprised to see how high we came. And we are now on the downslope. So as I think about coronavirus, we're somewhere in December, January of 1919, if we think that that's the right metaphor. But they saw another peak, at least in some places. So letting off is not necessarily the answer. Now, what they did not have that we do is vaccines and ventilators and other kinds of incredibly both advanced and basic supportive care. So the mortality rate is nowhere near what it was from 1918 flu, but still, this is an example. The other ones that really haunt me are things like this. So this is the map of Europe as Black Death spread across the mid 14th century. It came in waves. They knew it was coming. There were attempts to hold it back, whether through quarantine, through blocking travelers from visiting, preventing people that you didn't know from coming. It followed the Silk Road into Europe repeatedly from its original home in Central Asia. And it killed at least a third of the population. There's a lot of debate since exact numbers are not to be had. But this isn't actually the thing that scares me. What scares me is plague never left Europe. The last big global outbreak of Yersinia pestis, Black Plague, in the world was in 1898 to 1906 was the third plague, the third pandemic of a disease that smoldered in poor communities. It smoldered in folks who were poorly housed. It smoldered in places where people were neglected. So yes, the catastrophe of 1347, 1348, 1349, the second plague as it crossed Europe in the 1600s, the one where supposedly Isaac Newton was stuck in the library for a few months and developed calculus. That was the second plague, but the third one happened hundreds of years later because the disease persisted, and it persisted in places of neglect. And once a disease is as widespread as Black Death was in the 14th century, or as the coronavirus is today, the likelihood of ever completely eradicating it is extremely low. There's exactly one disease we have eradicated worldwide, and it's smallpox. So then I've been thinking about this other circumstance. First contact in North America. When Europeans came to North America and brought diseases that had not been known by those populations, and the death rates were astounding. Again, it's a circumstance where we don't have exact numbers, but best estimates are something on the order of 80 to 90% mortality, because more than half a dozen to a dozen different infectious diseases for which the population had no immunity were all brought at once. And over the period of decades, the best estimates are probably around 100 million Native Americans and folks who were indigenous to both American continents died. And the changes to the world were transformative for everyone involved. So we finally get control. We finally get some ways of dealing with infectious diseases where we feel like we can hold them at bay. Cholera in the 19th century was, again, a terrifying disease because you could catch it in the morning, as they would say, develop diarrhea, and dehydrate to the point of death in 12 to 24 hours. When cholera came to Europe and the United States, again along trading routes and in ships, it devastated Europe, it devastated America, and it traveled the world in pandemics. There's actually some interesting data to suggest that it may have been widely spread in bilge water from the Ganges River, where its native home was. But it's impossible to overstate the impact of cholera right up through the early 20th century. And it changed public health. It changed the structure of cities. It led to the creation of sewer systems and potable water systems and massive infrastructure all over the world in order to make cities safer to live in and in order to decrease deaths. So this is where we finally get to the point where, while they didn't completely get rid of cholera, it wasn't antibiotics, it wasn't vaccines, it wasn't antitoxins, it was pipes that really defeated cholera in the largest sense. And yet at the same time, we still have cholera. After the earthquake in Haiti in the last decade, cholera was brought to Haiti. We think probably by some UN soldiers in their bodies, and Haiti unfortunately suffered a cholera outbreak with deaths. Even now, even hundreds of years after we first discovered this disease. Here's the third cholera pandemic as it crossed the world. And again, the difference between the Black Death in the 14th century and cholera in the 19th century is we had truly global trade by then. So we had the ability to get a disease on ships and then spread it everywhere. And we did. We also had the ability to recognize what was going on. For anyone familiar with public health, this is a famous map of the Soho neighborhood in London, where physician John Snow in 1854 established that cholera was being spread by contaminated water in this neighborhood. And this was part of the larger public health argument that sanitary water supplies and sewer systems could defeat this terrifying illness. And then I think about public health more broadly. So again, magic bullets. I would love the vaccine to be a magic bullet, but the vaccine for COVID-19 is not our only tool. And this is the graph that I tend to think of when I think about why. Tuberculosis was the leading cause of death across Europe and the United States through the 19th century. It's a disease known to antiquity, but in the 18th and 19th century, as they first started to collect systematic, reliable death statistics, tuberculosis was the leading cause of death in the United States up till 1922, when it gets overtaken by all cancers. But 1922 is not a point on this map. That's the thing that's interesting. what Thomas McEwen, mid 20th century public health leader in Britain, was demonstrating with this graph is that mortality from tuberculosis had already declined in England and Wales, which is where this data is from, by more than 90% by the time we got streptomycin and other antibiotics for tuberculosis and the BCG vaccine. And so what was happening in that earlier period, and what lessons does it have for us? I will spare you the thousands and thousands of words that were argued and ink that was spilled in the British public health and global public health debate in the 70s and 80s over what was called the McEwen hypothesis. The gist of it is McEwen argued that the population was more robust to dying from tuberculosis because of better nutrition. Others argued that no, it was direct public health impacts like improved public ventilation, improved building ventilation. And I should tell you a little more about ventilation. So in the 1780s and 1790s, when they first started to do experiments in respiration, there was a recognition by the chemists and others who were working on this that oxygen was critical for maintaining life, and that too much carbon dioxide placed animals and ultimately humans at risk of death. But then there was a second recognition about carbon dioxide, and it was that carbon dioxide could be a marker of adequate ventilation in public spaces. Carbon dioxide buildup could show that there were too many people in an auditorium or a factory or some other kind of building, or that the ventilation was poor, and therefore be potentially a marker of the quality of the air. By the late 19th century and the early 20th century, the use of carbon dioxide as a marker of the quality of indoor air was well established, and there were established norms for how much carbon dioxide was too much. When we started to get mechanized systems of ventilation in buildings, fans, furnaces, forced air heat, other kinds of controls in the early 20th century, we start to get air conditioning and other kinds of monitoring. Carbon dioxide remained the major marker used to figure out, was there enough ventilation in this space up until the 1970s? Not because carbon dioxide itself was toxic at the levels that it was found in buildings, but because it was a marker for other things that other human beings could be exhaling that could be dangerous. In the early 20th century, the biggest concern was tuberculosis, but also when 1918 flu happened, it was something that was recognized as one tool for understanding, was this a healthy space for people to be in? And just yesterday in the Washington Post, I read about carbon dioxide measurements being used in Washington state now to figure out, is a restaurant safe for people to occupy? So the last 50 years, we've thought more about chemicals and other kinds of things that might be in indoor air, but the recognition that infectious diseases spread by other people could be spread in indoor air, and that we could do something about it, is actually much older than you might recognize. So here's the last thing that troubles me about magic bullets. Not everybody is getting them, and not everybody is going to get them anytime soon. So it's not just a matter of older Americans who are struggling right now to get vaccines because of shortages in the rollout. It's not just the fact that elementary school kids are probably not going to be able to get the vaccines until the end of this year or maybe into next year, because of they haven't yet been proven safe and effective in children. But the continent of Africa, that picture is terrifying. not just for the people of Africa, but for the people of the world. Because the critical thing to understand about infectious diseases is that no one is safe until everyone is safe. And when you think about emerging infectious diseases, I want you to think about, what do we mean by that? Emerging from where? Because usually emerging infectious diseases are emerging from animal reservoirs. They're emerging from neglected populations. They're emerging in the United States from Skid Row, where the main reservoirs for tuberculosis in the mid-20th century, after widespread availability of antibiotics, were in marginalized populations, homeless populations, prison populations. Even worse than that, in prisons where people get intermittent access to antibiotics, all over the world, we have cultivated multiple drug-resistant tuberculosis. So when we think about emergence, we're really talking about neglect most of the time. Neglect of people, neglect of human-animal interactions in the way that they might put us in peril, and circumstances where it's actually quite predictable where the infectious diseases are going to arise. There's been some great work done in, among other places, Chicago, showing that more than a quarter of the drug-resistant tuberculosis in the city of Chicago can be traced to its prisons if you do genetic epidemiology. Not because that many people are in prison, but because people cycle in and out of jail when they get arrested, and because prisons and jails are staffed by people. And so the guards and the nurses and the police officers and the lawyers and everyone else who is not imprisoned, but who spends time with incarcerated populations is potentially both at risk and a vector. We saw the same thing with nursing homes in this pandemic. So here's what, even if you didn't care about the billion people who live in the continent of Africa, it's in your interest to care, because they're probably the most likely source of resistant and mutant variants of COVID-19. And we have already seen this with the COVID-19 variant from South Africa that is now spreading all over the world. And there's some really interesting brand new data, and here's some links to some of it, that some of the more troubling new mutations are arising in people who are immunosuppressed. So the individual is immunosuppressed, they get infected with the virus, their body is unable to fight it off. They get chronic and sustained infections over a period of weeks to months. And in those settings of chronic and sustained infections, the virus mutates inside their body. There was a nice study out of South Africa just recently showing that if you did serial testing of the virus in an individual with HIV, you could find different mutations over time. Russell, you have to say hi to everybody if you're going to come visit.
Hi.
So the South Africa strains that we are most worried about also arise out of neglect. They arise, think about it. South Africa for many years has had the highest rate of HIV in the world, along with some other parts of Southern Africa. And even though they have more resources than many of the countries in other parts of Africa, they also have more trade. And so that has placed them at risk for getting more tuberculosis, more HIV, and now more coronavirus. And even as a resourced middle income country, they have struggled, like everyone has struggled, to deal with infectious diseases in their population. But if all the people with cancer and on Humira in Europe are potentially the greatest risk for a rising of mutant strains of coronavirus, and all the people with HIV in Africa are potentially hosts in whom the most dangerous resistant strains might be spread, then we really have missed the boat in understanding where our risk lies if we decide that it's okay that it'll be 2 years before most of Europe and most of Africa gets vaccine. So how do epidemics end? And the question I have is, what is the end? So if you ask historians and sociologists of epidemics, as I had the chance to do earlier this year, what they said is endings are messy because typically, except for in the case of smallpox, we don't have an end where the disease disappears. We don't eradicate the disease. So how do we decide what is the end? And polio is the other disease where I've been thinking a lot about this, because we've been trying to eradicate polio for more than 20 years. And a handful of cases in Afghanistan and Pakistan, and then repeated reintroductions of polio from those communities to other parts of the world have prevented our ability to completely get rid of it. So we are not going to wait to declare the end of the coronavirus pandemic when we get to zero, both because that doesn't necessarily make sense, in the sense that the declaration of an epidemic or a pandemic is that the disease is above the rate you would expect in a population and that you should do something about it. So while there is a technical definition of epidemic and pandemic that in particular the WHO is the custodian of, it's also a metaphorical statement. It's a political statement. It's a moral statement. To say that something is an epidemic is not just to say that it is infectious. We declare many other things epidemics. It's to declare that we should do something about it. And so if we reach a point where there are, where caseloads have declined a fair bit and we decide that it's okay to resume normal life, that's when we're going to say the epidemic is over, even though there's still going to be residual cases. But once we do that, what are we going to do for those people? What are we going to do for those communities? What is it like to be the last person to die of an epidemic disease? What is it like to be the last person paralyzed by polio? You can talk to folks who can tell you that answer, because resources shift, attention fades, the will to do something about it changes. And especially if those reservoirs are left in neglected populations, that's how we get recurrences. That's how we get to the point where we decide it's over, and so we move on, and then it comes back. So how are we going to address the needs of those who are not cured or not met with our initial efforts? And how are we going to make sure that that moving back to normal life does not mean forgetfulness and neglect? Again, kind of the standard public health statement about infectious diseases: no one is safe until everyone is safe. And with that, I would love to have a discussion.
All right, thank you very much for that, Dr. Carla Keirns. And I would just like to remind everyone that that this is a kind of a discussive session, so you can use the Q&A tool or the chat tool to submit questions or comments, any other contributions, and we can read them into the chat. I think one thing, while we wait for some of those to roll in, one thing I'd just like to note, and maybe you can speak to this a little bit, is how interesting it is that how much of this is like all wrapped up in the way that our like economy and political economy are set up. right? That it's like our biology is a part of it, and being able to like achieve vaccination or immunity are important parts of this. But like in the same way that the virus travels around in your blood, the virus also travels around in like sort of like the economic lifeblood, right? In the trade routes, and then the way that that these things are all set up, and obviously necessitates intervention that happens in those spaces. If you're interested in speaking to that a little bit more.
Absolutely. So, so that's exactly right. The reason that historians and sociologists have found epidemic diseases fascinating is because of what they reveal about social structures, and whether that is trade routes and travel, or whether that is who do we try to rescue and who do we decide not to, is really profound, both as a political matter, as a moral matter, and as a public health matter. The Black Death and the Silk Road is just something that has really always stuck with me, and cholera and 19th century trade and travel. Again, the thing about cholera is they had telegraphs and they had newspapers that could publish the news because of the telegraph around the world. So when cholera went from India to Europe to the United States, they knew it was coming. In the same way, if not at quite the same speed, but almost the same speed that we know.
Carla, thank you for doing this. This is fascinating. I've got a question back on one of your slides. I think it's the 1852 slide. So the interior of Africa was obviously completely, I guess, not completely, but looks to be very unaffected. And I assume that has to do with there wasn't a lot of transportation. There wasn't a lot of trade going on within the interior of the continent, yet there was on the coast. And it's just clear that that's what happened. And we're no longer in that situation, as you mentioned. So now this is the global, we got a global environment and global travel. So help me understand. We talked about this at the National Association of Bioethics Program Directors the other morning about we are really being delinquent right now with our, total navel gazing that we're doing about we got to get this fixed in the United States, because it isn't over till it's over for everybody is really most important. How would you suggest that we balance the focus of the development of the vaccine and the distribution of the vaccine, where those of us who can, again, in this society, hunker down and isolate ourselves without any jeopardy to make sure that we get it to the right people? What are the public policy levers that we really need to look at here?
So a lot of folks have been doing very thoughtful work on vaccine allocation. And the biggest factor is that some people are calling it vaccine hoarding. Other people are just saying, Europe and the United States have both signed advanced contracts for 4 times as much vaccine as their populations will need. And that it may be in our interest to share more of it faster, particularly to prevent the growth of these kinds of resistant strains. There's still a moral case to be made for the welfare of people all over the world, but politically, in some ways, it's often easier to make the political case that if we don't send some vaccine to South Africa pretty soon, we're going to be sorry too. Because and there have been efforts. There is an international pool of vaccine that the countries have been willing to donate to. Norway has done the most to share with. I just wanted that map to be visible. Norway has done the most to share with other countries already, and other places where we sort of think sharing and doing the right thing for global health might be politically feasible, like Canada, have pulled back just because there is so much demand among their population to get vaccinated sooner. So I think we need to help everybody see and understand why it is that it might be better for my kid if South Africa gets vaccine before he does. But that's a really hard thing for most people to accept.
Thank you.
Yeah, we have a question here from Noreen. She's thanking you for the presentation and asking what could we as individuals do to help with the issues discussed about Africa and kind of the differential, and then also are there organizations working towards correcting the deficit? You mentioned kind of an international pool. Do you know of others?
Yeah, there are. Sort of the usual organizations that focus on health and healthcare in Africa would be important, and letting your legislators know that that you support the U.S. being involved in those kinds of bodies. So you can donate to some of these international organizations that are doing that work. But USAID and PEPFAR and some of the other Global Fund kinds of groups are the ones who have the most infrastructure in place, as well as this new vaccine effort. So I think that individual donations and political voice are going to be important, because otherwise our politicians are going to assume that that Africa is really far away, and that that we are being more selfish as individuals and as a society.
Yeah, structurally, there's some difficult hurdles there. I mean, a representative is like they take an oath to serve a specific geographic unit, right? And this kind of the interesting, like just having to rotate the way that we think about those kinds of problems.
I mean, I would love to talk to the representative who has Atlanta Hartsfield Airport in their
yeah, absolutely.
An 18-hour flight to Johannesburg.
Right.
They could have, I mean, it's not surprising that that they saw early introduction of the South Africa strain.
Yeah.
I know you're not an infectious disease doc, but can you talk about the lethality of the variants a little bit more? I know that so are individuals who possibly HIV people who manufacture these variants quicker than the rest of us would, are they more susceptible, and are older people whose obviously immune systems are diminishing, are they going to be as susceptible to the jeopardy of a new variant than they would be otherwise, even if they're already vaccinated?
So again, this is evolving data, but my best understanding of it is that they are spreading because they are easier to spread, but they tend not to be more lethal than the strains that we've had before. But they will kill more people because they're more, yeah. Okay. And so the estimates are that the reproductive rate, the number of people that I would infect if I got it for the original strains, are on the order of 2 to 3, and for the new ones, it's more like 4. So it's not that much unless you recognize the arithmetic of geometric growth. It does become more.
Do the math, right?
Yeah, right. Become more very quickly. But those folks are at high risk of dying also from either the new strains or the old strains. But in the 100 days it took that South African patient to die, 101, many different mutations incubated in his body, which is frankly terrifying.
Yeah, horrifying. We have another question here from Terry. It says, thanks, and I'm wondering if some pandemics end with a whimper. My father was born in 1926 and commented frequently throughout the past year that he never heard anything about the horribly deadly pandemic occurring just prior to his birth. It was like it had just never happened. No one in his family or community said anything about it. I understand that the Spanish flu might have been politicized. So has this pandemic. Might it end with a whimper?
It might. Alfred Crosby is the first historian who wrote in English about the 1918 flu, and his book is literally called America's Forgotten Pandemic. So it's partly because 1918 came amidst World War I. It's partly because news of it was literally suppressed because of World War I. But yes, often what happens is that we move on to something else and we forget about it, rather than declaring it over, partly because it's often not over, but something else becomes more dominant. And so the usual dynamic is precisely what Terry's describing. Unless you can call a triumphant end like the polio vaccine or the vaccine for rubella that stopped an epidemic of birth defects in the 1960s. If there's not a something to champion, it's usually more about moving on to the next thing.
Yeah, it's interesting how these sort of domains that are like kind of clearly distinguished in our minds, the political, the biological, the economic, whatever, like they resist being disentangled in reality, right? Like you can't like, you can like declare victory from like a political standpoint, and then you get a big resurgence. It doesn't work that way. Yeah. We have another question here, maybe kind of a more general one. John can probably speak to this too. It says, what do you think are the most ethical ways to distribute a limited supply of vaccine, i.e. who first? Are there ethical ways to decide this?
I am going to defer to John because I know he's been.
Thanks for that. Well, let's just say we haven't done a very good job of it. I think the constructs are pretty much similar to the way they should have been for testing and tracing, at least with this pandemic. And we screwed that up totally. So, we really haven't done a very good job. So we know who the people are and we know where they live. What I find frustrating is that there doesn't seem to be the political will or the energy to zero in on those neighborhoods and those census tracts and stuff like that. We've got it. We have a pandemic vulnerability index that's been developed. We've got a deprivation scale. We've got other types of socioeconomic and social dimensions for deprivation as well. So I'm not astounded, I guess. It's overcoming. Back to your point, Carla, that you've made so well today, is that this is much bigger than us. It's much bigger than me and my family and my little tribe. And until we really address that, we've got to be able to do it. The other thing that I find particularly frustrating, having dealt with a lot of issues on the 2009 H1N1, there really was, and maybe we were pretending that it was a much more defined structure or process, federally mandated and flow, everything kind of flowed downhill, even in the transportation of vaccines and everything else. It turned out not to be as bad as everybody thought it was. So much of what we had to face didn't have to happen, but it was a much more coordinated federal plan. And I think that looking back in 5 years from now, what we're going to really see is the lack of support at the federal level and the state level for you can do this at the community level, but you've got to have the support systems in place above that in order for it to work. You've got to know that the distribution networks are in place. You've got to be able to make sure that they're delivered, and that the partnerships, if there is partnerships between public health and private business, that they're working, they're functioning, and everybody is agreeing that we're going to follow the rules and go forward with it. So I think there's going to be, from your perspective as a historian, there is going to be a lot of work to be done over the next 5 years, looking back at this and saying, this is how how not to do it, and we need to move forward. So I think the ideas about being able to identify with those deprivation scales and then really committing to it, mechanisms that community-based organizations, trusted leaders, especially related to reluctance and hesitancy. I think it's not rocket science. We can figure this out, but we've got to first say that somebody else may be more needing of this intervention than I am.
But that's why they're vulnerable to start with.
Yeah, it's unfortunate that it's like the divides fall along the same place.
They do. They do the same markers. Yes.
All right. I guess we're coming up on 1 o'clock, and I just want to be respectful of everyone's time. Looks like we have maybe one last question that we can maybe squeeze in here. That says, can you speak to the likelihood of this virus persisting as a perennial illness, one for which there may need to be repeated measures to control spread, i.e. boosters, and over what period of time?
Yes. So some really interesting work has been done showing that if you do genetic and phylogenetic work on flu, the 1918 flu never left either. So we still don't know how long immunity for this is going to hold, but every expert I have read and talked to thinks that we're stuck with this.
Yeah.
This virus is not going away.
Yeah.
And one more haunting thing, it's also not going away in our bodies, not just in our population. So we don't even know, and it may be decades before we know, are there long-term effects from exposure? So we know I had chickenpox when I was 3. As a result of having had chickenpox when I was 3, I remain at risk for the rest of my life for the fact that that virus is hiding somewhere in my nerve cells. We know that measles hides in people's brains, and in 1 in 100,000 or 1 in a couple 100,000, extremely rare cases, it reemerges 20 or 30 years later as a form of intractable epilepsy that's universally fatal. And we don't know whether there's something like shingles or something like subacute SSB, I think it is the measles form of epilepsy. We don't know if there's something like that from COVID, but if you listen closely to what Anthony Fauci and other experts have been saying for the last year, they're worried that there may be something like this. Viruses can persist not just in populations, but in our bodies. And so we let this get out of control, and now we are stuck with it.
So if the stakes weren't already high enough.
Well, on that happy note, thank you very much for your presentation today.
Yeah.
This has really been fascinating. Thank you so much, Carla.
Dr. Keirns, thank you very much. And yeah, just to close this out, I'd like to remind everyone that these sessions are recorded. You can find them on our YouTube channel. Just go to YouTube and search for Practical Bioethics. You can find the back episodes and this episode there. And we'd encourage you to visit our website and look at our events calendar. We've got some great stuff coming up, and you'll be able to find information about that there. So once again, thank you, Dr. Keirns. Thank you, John, for being on, and we will catch you next time.
Thank you.
Thanks.